Welcome to the Deep Dive. This is where we take your sources, notes, articles, whatever you send, and really break them down, get to the core insights. Today, we're tackling a specific medical topic. We've got a great set of revision notes someone shared on breast abscess. So our mission, really, is to convert these notes into a super clear, high-yield overview. Perfect for revision, pulling out the key bits.
Exactly. We'll walk through the structure of these notes. We'll cover the definition, what causes it, the risks, how it develops, what else it might be confused with, how common it is, investigations, management, prognosis, and, any potential problems.
Yeah.
So for you listening, think of this as just a really structured way to absorb this info. Make it stick for when you need it.
Okay, let's get started. Definition first. What exactly is a breast abscess? What are we talking about here?
Right. So the notes define it simply. It's a localized collection of pus right there in the breast tissue. And they link it straight away to bacterial infection. That's usually the root cause. Often follows on from mastitis, inflammation of the breast.
Okay, so infection leads to inflammation, and then the body sort of walls off the pus.
Yeah.
Creates that pocket.
Precisely. It's containment, but it forms the abscess.
And the notes mention types, lactation versus non-lactational. How do they differ?
Yeah, that's a really key distinction. Changes the picture quite a bit. So lactation abscesses happens in breastfeeding women, as the name suggests. They tend to be more towards the edge of the breast, peripherally.
Okay.
Then you've got the non-lactational type. These are often connected to something called periductal mastitis, inflammation around the ducts, usually just under the areola. The notes mention links to nipple inversion here, and it's seen more in younger women, sometimes those with compromised immune systems, like diabetes is given as an example.
Right. So straight away, that gives you two different patient profiles to think about. Depends heavily on whether they're breastfeeding or not, and maybe other health factors. That's useful. Okay, let's move to why it happens, the etiology. What are the main bugs involved here?
Well, the notes are clear. It's primarily a bacterial infection, and the main culprits listed are Staphylococcus aureus, Staph aureus, very common, and Streptococcus species. They also mention a few others you might see, though maybe less often, like E. coli, bacteroids, and, other types of strep.
So mostly staph and strep, but good to be aware of the others too. Knowing the likely bacteria helps with treatment choices later. Right?
Absolutely.
Now, who's more at risk? What factors make someone more likely to develop a breast abscess, according to these notes?
Okay, several factors are listed. Breastfeeding is a big one, tying back to the lactation type, especially if there are, say, difficulties with latch or cracked nipples, gives bacteria an entry point.
Makes sense.
Also, if someone's had mastitis before or other breast infections, that increases the risk. Inadequate breast hygiene is mentioned, makes sense, bacteria on the skin. And then more general health things, conditions like diabetes or anything that weakens the immune system, makes it harder to fight off infection. And interestingly, smoking is listed too, particularly linked perhaps to the non-lactational type, maybe affecting tissue health around the ducts.
That's a helpful list.
Yeah.
Helps you spot who might be higher risk and maybe areas for prevention advice like breastfeeding technique or managing diabetes. It connects the dots.
Okay, the pathophysiology, this is always interesting. How does that bacterial infection actually turn into the abscess, that walled-off pus? Can you walk us through the steps?
Yeah, it's basically the body's inflammatory response kind of escalating. The notes lay it out clearly. First, bacteria get into the breast tissue through, like we said, damaged skin, a crack maybe, or sometimes up through the milk ducts.
Okay.
Once they're in, they multiply. The body spots the invasion and kicks off inflammation, sends immune cells, increases blood flow.
Yeah.
The usual defense.
Right, fighting the infection. Exactly, but if the infection isn't cleared quickly, that inflammation can cause tissue damage. You get a buildup of immune cells, bacteria, dead tissue, pus, basically. And the body's reaction is to try and contain that mess. It builds a wall around it. And that walled-off collection is the abscess.
So it's like a battlefield, and the abscess is the body trying to quarantine the fight. Clear progression. Bacteria in, inflammation, containment failure, leading to the pus pocket.
Precisely.
All right, let's shift slightly.
Yeah.
Someone comes in with breast pain, redness, maybe a lump. An abscess is possible, but what else could be going on? What's the differential diagnosis list from these notes?
Yeah, this is super important clinically. Some alternatives are serious. The notes list a few key things to consider. First, just mastitis itself, so inflammation, but without that distinct pus collection yet. Similar symptoms, pain, redness, but maybe not that fluctuant lump.
Okay, the precursor almost.
Kind of. Then, more worryingly, inflammatory breast cancer.
Yeah.
It's rarer, but aggressive, and it can look a lot like infection redness, swelling, warmth, pain.
Wow, yeah, that's a big one not to miss.
Definitely. The notes also mention cystic breast masses, just fluid-filled sacs, not pus. Benign tumors like fibroadenomas, these are solid lumps, not infection. And lipomas, benign fatty lumps, also on the list.
That really highlights why you can't just assume.
Absolutely. You've got inflammation, infection, benign things, and cancer all potentially looking similar initially. Makes the history, exam, and especially investigations crucial.
Okay, how common is this? Epidemiology. What do the notes say, especially thinking about the UK context they mention?
Well, the main point is it's much more common in women of reproductive age, and especially during breastfeeding. Again, linking back to that lactation type.
Right.
They do mention that specific UK-wide data might be hard to come by, or at least wasn't in these notes, which is fair. Sometimes that level of detail isn't available for revision notes, but they give a really useful figure connecting it to mastitis. They say approximately 3% of mastitis cases go on to become a breast abscess.
Okay, so maybe not super common overall, but definitely a known complication of mastitis. If you see mastitis, you know there's roughly a 1 in 30 chance it could develop into an abscess. That gives a good sense of scale.
Exactly. Especially relevant for that reproductive age group.
So how does it actually look? The clinical features. What signs and symptoms make you strongly suspect a breast abscess?
The notes paint a pretty classic picture. You get localized symptoms first. Pain in one area of the breast. It's tender to touch, feels warm. Visibly, there's swelling and redness over that area. And because it's an infection, the patient often feels generally unwell. Systemic symptoms like fever, chills. That suggests the infection's having a wider effect.
Right, not just local anymore.
Exactly.
Yeah.
And then the key physical finding, palpating, feeling a mass or lump that is fluctuant.
Ah, that word again.
Yes. Fluctuant means you can feel that sort of liquidy shift inside when you press it, like a small, tense water balloon under the skin. That really points towards fluid, likely pus, rather than solid tissue. Sometimes nipple discharge, too. Could be pus, could even be blood, the notes say. And then they specifically pull out key points that raise suspicion if you're already thinking about infective mastitis. Fever, feeling unwell, maybe nausea. That painful, swollen, fluctuating lump with the redness and heat. A history of recent mastitis is a big flag. And that pus-like nipple discharge.
That fluctuant feel sounds absolutely key on examination, and tying it together with systemic symptoms like fever and maybe recent mastitis, it paints a strong picture.
It really does.
Okay, so we suspect it based on the symptoms and exam. How do we confirm it? What investigations are typically used according to these notes?
Right, the standard pathway. Starts with the clinical assessment, good history, thorough physical exam focusing on those features. But imaging is really key for confirmation. The notes mention ultrasound or mammography. However, they really emphasize ultrasound. They state suspected cases need an urgent referral for ultrasound, so that's clearly the main tool.
Okay, ultrasound's the go-to.
Definitely. And crucial for revision, they describe the ultrasound appearance. It shows up as a hypochoic collection. Hypochoic just means darker than surrounding tissue, suggesting fluid. Inside that collection, there's no vascularity, no blood flow within the pus itself. It's described as having fluid content. And often, there's an echogenic or vascular rim around it that's the inflamed wall of the abscess, looking brighter or showing blood flow.
Knowing those specific ultrasound features sounds vital. Hypochoic, no flow inside, fluid, bright rim.
Absolutely high yield for recognizing it. Mammography gets a mention, but the notes say it's rarely used here, maybe in older patients or if things look unusual, mainly to help rule out cancer. And finally, aspiration, putting a needle in to get fluid or biopsy, is mentioned but described as rarely needed, suggesting the diagnosis is usually pretty clear from the clinical picture plus the ultrasound.
Got it. So clinical suspicion points the way, but ultrasound is the key investigation to confirm it and see those characteristic features.
That's the takeaway.
So once it's confirmed, how do we manage it? What's the treatment plan, especially in the UK context these notes refer to?
Management has two main pillars, really. Dealing with the infection and dealing with the pus. So first, antibiotics. Broad spectrum ones to cover the likely bacteria. They mention flucloxacillin as an example, or clindamycin for penicillin allergy.
Yeah, hit the bugs.
Exactly. Then second, you often need to drain the abscess. Get that pus out. This can be done by needle aspiration, just sucking the pus out with a needle and syringe. Or sometimes, especially if it's larger or doesn't resolve with aspiration, incision, and drainage or I&D, making a small cut to let it drain properly.
Right. Physical removal of the pus.
hmm And of course, pain relief is important too. Simple things like paracetamol. And a key point, especially for lactation abscesses, they stress that continued breastfeeding or expressing milk is usually okay and should be encouraged after treatment starts. Helps prevent milk buildup.
That's important practical advice.
Yeah, the additional info section adds a bit more detail. It lists other antibiotics that might be used after drainage, like coamoxiclav, erythromycin, or metronidazole, depending on allergies or specific sensitivities. It also notes that the ultrasound confirmation and the drainage procedures are often handled by general surgeons in secondary care. And again, it reinforces encouraging continued breastfeeding or expressing milk, important for recovery and maintaining supply.
So it's really a combination approach.
Yeah.
Antibiotics for the infection, drainage for the pus collection, plus supportive care like pain relief and advice on breastfeeding. Sounds like a coordinated effort.
It is. Often involves primary care, identifying it and referring it, then secondary care, usually surgeons, confirming with ultrasound and performing drainage alongside the antibiotic treatment.
Okay, moving towards the end. What's the usual outcome? The prognosis for someone with a breast abscess?
Generally good, according to the notes. They say the prognosis is favorable with proper treatment. Basically, most people respond well to that combination of antibiotics and drainage.
That's reassuring. It's definitely treatable if managed correctly.
Yes.
Are there any potential problems or complications that might pop up?
The main one mentioned in these notes is recurrence. The abscess can come back sometimes.
Okay. So even with successful treatment, it's possible it could happen again, something to be aware of.
Exactly. Might mean looking closer at underlying risk factors if it does recur.
And good practice, the notes cite a reference.
Yeah, they mention the CKS NICE guideline, Clinical Knowledge Summary from NICE, a standard UK resource.
And they finish off just mentioning a couple of websites.
Right at the end, they list passthemsra.com and freemsra.com. Seems likely related to medical exams or revision, probably where these notes came from.
Okay. Wow. That was a really thorough walkthrough of breast abscess, following the structure of those revision notes perfectly. Definition, causes, risks, presentation, diagnosis, treatment. We covered a lot.
Yeah, breaking it down like that, section by section, as the notes did, really helps make it high yield. Focusing on those specifics, the lactation versus non-lactation types, the key bacteria, the risk factors, that fluctuant feeling, the ultrasound signs, the antibiotics plus drainage that makes it stick.
Definitely feels less overwhelming when you tackle it in chunks like that. You can see how it all fits together.
Exactly. And remembering those key diagnostic clues, the clinical signs, the systemic symptoms, the context, and especially the crucial role of ultrasound, those are probably the most important bits to retain.
So thinking about this for you, the listener, if you're revising this or maybe encounter it clinically, having that structured framework from the notes is just incredibly useful for recall, for making sure you haven't missed anything. It's a solid mental checklist.
Which leads to maybe a broader thought.
Yeah.
How else could you apply this kind of structured note-taking or thinking, breaking down complex topics into logical sections like definition, causes, management, etc., to make other medical subjects easier to learn and revise?
That's a great question to ponder. How can you structure your own learning effectively? Something to think about. Well, that brings us to the end of this deep dive on breast abscess. Thanks for joining us. And thanks again to the listener who provided the excellent notes, including the NICE reference and those website mentions at the end.